All right. Well, welcome everyone to another episode of the Blood Sugar Hotline. I'm Wolfram Alderson, and I'm here with Roberta Ruggiero, and our guest today is Dr. Mary Elizabeth Patti. We're really excited to have Dr. Patti here. We've really been following her work since she's a leading expert in the condition that the Hypoglycemia Support Foundation has been researching and writing about for over 4 decades. Dr. Mary Elizabeth Patti is a physician scientist. She serves as principal investigator at the Joslin Diabetes Center, director of the Hypoglycemia Clinic, co-director of the Molecular Phenotyping Core, and associate professor of medicine at Harvard Medical School. And I guess I would imagine you probably have a few other titles that you haven't shared with us yet.
Not important.
So anyway, thank you for joining us. It's really a pleasure to have you here. So welcome, and we just want to greet you and thank you for joining us today.
My pleasure. Always happy to talk about hypoglycemia.
Great. Well, we're going to jump right in and love to have you tell us a little bit more about you and your work, how long you've been in this field, and why did you choose this area of work? Just let us know, please, how you came down this path and what it is you do.
Well, I've always been interested in glucose metabolism and other facets of metabolism throughout the body. And so I was interested in endocrinology, so came here to Harvard to do an endocrinology fellowship, and then stayed on after that was completed. I have always been interested in hypoglycemia as a subset of an important component of understanding metabolism, and have been really investigating hypoglycemia from a clinical research perspective for about 15 years. After we received a number of consults in the hypoglycemia clinic from patients with severe hypoglycemia who had previously had gastrointestinal surgery. And so as an endocrinologist, it's important to understand what's going on so that you can better treat patients and try to help them better. But as an investigator endocrinologist, it was also clear that we didn't really understand enough about this condition. And that was an important research goal as well. So things progressed over time, and now we have a uniquely devoted hypoglycemia clinic here at Joslin for patients without diabetes, and an active clinical research program in our clinical research unit. So it's really been a pleasure to have the opportunity to interact with individuals with hypoglycemia, as well as to do studies which have increased our knowledge in this area. We still have a long ways to go, but it's still a process.
Well, thank you. I know Roberta's going to have questions, but first, just it may seem obvious because we're the Hypoglycemia Support Foundation. Many people who follow us probably already know what hypoglycemia is. But would you just give us a quick sort of clinical definition of what hypoglycemia is?
Sure. I think that's important. Hypoglycemia is really defined as low blood glucose. And why is that important? It's because tissues in the body need glucose to function normally. So if the glucose level falls to a range that's below normal, that can affect many organs, but most concerning is when the brain doesn't function well. And that can lead to a variety of different consequences, which are both unpleasant and sometimes dangerous.
And what is that threshold, the official threshold for?
Well, so officially over time, the definition has evolved. There's no black and white definition of what's normal and what's abnormal. It really depends on when and how you're assessing glucose levels. Traditionally, fasting glucose values under 70 have been considered as hypoglycemia. And values under 54 more severe. So I would say that's probably the definition that we should use. Now that we have continuous glucose monitors, people are starting to look at glucose patterns and numbers with continuous glucose monitors, but those are not measuring the same thing as a glucose level in the blood. So it's important not to take those same normal ranges and apply them to continuous glucose monitor information.
The continuous glucose monitor measures interstitial fluid, again, for people who don't know. So there's some delay and perhaps some variance in the numbers between what's in the glucose that's in your blood versus your interstitial fluid.
Correct. And, you know, if you look at continuous glucose monitor results from absolutely healthy people who don't have any complaints, no diabetes, no other systemic illnesses, you know, people can have glucose levels under 70 quite a bit of the time, but usually not below 54. So, I think that there can be low normal range glucose levels and then glucose levels that are in the more severe range below 54. And obviously when that occurs, those are the more dangerous values.
You did mention when and how we assess glucose as being a factor. One thing we've noticed when speaking with the members of our community is people obviously are unique, and every organism is unique, every metabolism is unique. And some people experience severe symptoms, mental, physical symptoms at 70 or numbers higher than what might be a critical level. So, what people actually experience physically and mentally at different levels is often unique, correct?
Absolutely. I think there are some individuals certainly who have symptoms when their glucose is dropping rapidly. We don't fully understand, but there's a possibility that their symptoms are related to other hormonal changes that are occurring and not the glucose itself. So the glucose may be on its way down. These other hormonal changes cause glucose to go down, but some of the symptoms they're feeling may not be the glucose per se. So that's where the confusion often lies for both physicians and patients, because, clearly they're having symptoms, but it doesn't necessarily always coincide with the glucose being abnormal.
Yeah.
Dr. Patti, can I ask a question? Most of the people that get in touch with us have been going around and around trying to find a doctor that even recognizes and treats hypoglycemia. How do they find you? I mean, we haven't really known about you and your clinic, but for the last 3 years, and we were so excited. So I'm so sorry that we didn't know, because we found out that your clinic is like, 20 years old. So do the people that get in touch with you, are they severely sick? Is that how they, find you? You've gone from doctor to doctor, and now, oh my gosh, we finally found Dr. Elizabeth Patti, or, so.
I think a lot of times you're right. It's frustrating for patients because, hypoglycemia is not as common as diabetes. So there are more doctors who are more comfortable with managing patients with diabetes than there are with patients with hypoglycemia. So I think it's really a level of comfort that a lot of physicians just don't feel comfortable with evaluating patients. And so they, as time goes on though, and as we reach out to the medical community more, and for example, see more and more patients who have hypoglycemia after gastrointestinal surgery, I think more endocrinologists are becoming more comfortable with the idea that yes, hypoglycemia exists, and it can be treated. And, you know, we can't see everyone who has hypoglycemia, but I think that increasingly there are more endocrinologists who do feel comfortable taking care of patients with hypoglycemia. And we certainly try to promote education at physician conferences, endocrinology conferences. So at least in the endocrinology community, I think that that's where people should start. And then if there's a particularly challenging issue that their endocrinologist can't handle or isn't clear about, they may want to get in touch with our team. For example, their endocrinologist could contact us and ask for some suggestions. So there are many options now, and I think increasingly so.
Dr. Patti, we're going to ask you about post-GI surgical hypoglycemia in a little bit, because I know that's a topic that's of special interest to you and maybe also not getting the attention it deserves. In fact, we host a petition on our website to encourage, healthcare to provide more support for that issue. But could you set the context a little bit? Because sometimes we talk about hypoglycemia, and we're guilty of it as well, since the Hypoglycemia Support Foundation tends to focus on the diet-related sources and types of hypoglycemia, reactive functional hypoglycemia, postprandial hypoglycemia. But there's so many different types of hypoglycemia, and it seems like it's associated with almost every major chronic disease that I've heard of. If you just, type in, cancer and hypoglycemia or any major condition, it, comes up as a cofactor. Would you just kind of maybe just briefly lay the context? Because if hypoglycemia is the elephant in the room, it seems like there's a lot of blind men looking around, walking around it and defining it in their own, their own way. And maybe you could just give us a big picture view that, the sort of the key types of hypoglycemia. And then please, we want to hear more about post-bypass surgery and how it emerges. That condition.
Well, I think it's always helpful to put on a hat. Why don't more people become hypoglycemic? So, regulating glucose is an essential function in the body, right? Keeping it in a range that's not too low, so people are safe, not too high, so there's no diabetes. So this is an orchestrated control system that the body has developed over eons of evolution to keep the blood glucose in a very tight range under normal situations. And so many things can interfere with these pathways of that regulate glucose. And, it's not only the pancreas that makes insulin, which obviously lowers glucose, or glucagon, which raises glucose. Both of those come from the islets in the pancreas. So that's one tissue. But other tissues are really critical, like the liver. The liver is a key component of regulating glucose, because if the liver doesn't make enough glucose when you're fasting overnight, for example, when you're sleeping, then the glucose can fall over the course of the night. The kidneys are important. The brain is important. The adrenal glands are important. All of these organs play a role in secreting hormones, making glucose, and if any of these things are perturbed, the glucose can either rise or fall. There are a lot of medications that we use that can cause changes in glucose, both increases and decreases. There are other factors too. For example, alcohol is something that can change the metabolism in the liver, making it more likely that someone will have a low blood glucose. So there are many things, and one of the key take-home messages is that if someone has hypoglycemia, they really do need to see a doctor so that they can exclude all of, evaluate all of these potential hormonal and organ contributors to potential hypoglycemia. So
Dr. Patti, I was absolutely surprised because, you know, I've been trying to read everything I possibly can over the last 40 plus years to learn about the correlation between hypoglycemia and thyroid. I just didn't realize how, you know, if your thyroid is off, how it could affect your glucose. So that's another area maybe we can get into next time, because I know that, you know, there is something special that you want to speak about. But have you seen that correlation?
Well, if someone has severely low thyroid hormone levels or severely high, it usually is sort of extreme examples of uncontrolled thyroid disease. That certainly can affect glucose levels, because thyroid hormone affects all of those other organs that I just mentioned. So yes, these are all intertwined, and abnormalities in a variety of organs can contribute to change glucose metabolism.
Wow.
Yeah.
Well, thank you for that overview. I think we could spend a whole program just looking at the various forms and symptoms, and you mentioned all your overview of the tissues and hormones. I mean, there's just so many aspects to this, and it's a really rewarding area of work because there's just something new you can learn every day in this field. I'm sure
Absolutely.
that's the reason why you've immersed yourself so much in this area. But we do know that you have a special concern around gastrointestinal bypass surgery and how hypoglycemia can affect some of those patients. Would you set the context for us again, just a little bit? You know, again, maybe obvious why somebody has gastric bypass surgery, but maybe you could just explain, first of all, why folks have that surgery, why it may be necessary for some folks, and then, of course, dive into this special concern that you have.
Sure. I just want to make one other comment before I go there, and that's that, you know, we still have a lot to learn about metabolism and what regulates glucose metabolism. We don't have all the answers. So, you know, sometimes as best as we try at the moment, we may not have the precise molecular diagnosis for everyone. But that's why research is so important. And that's why we continue to try to accumulate more information about these conditions. So, why am I interested in hypoglycemia after gastrointestinal surgery? Because it's increasingly probably the most common cause of hypoglycemia that we see as endocrinologists, and increasingly recognized in the general community, both primary care practitioners as well as surgeons who take care of patients who've had upper gastrointestinal surgery. So what do I mean by upper GI surgery? Well, there's a whole host of different types of surgeries that are done on the esophagus, the swallowing tube, as well as the stomach. To give you a range, people may have esophageal surgery because they've had a tumor. They may have severe reflux where the stomach acid goes into the swallowing tube, and they have to have a surgical procedure to reduce that problem. So it can be an esophagus surgery, or it can be a surgical procedure on the stomach itself. Why would somebody have surgery on the stomach? Again, it could be severe ulcers, could be a tumor of some type. But nowadays, the most common reason that people have stomach surgery that then can cause hypoglycemia is because they're looking for assistance with improving their body's metabolism in the setting of excess weight and type 2 diabetes. So bariatric surgery, which is a broad term that includes gastric bypass surgery, as well as a more commonly used procedure now called sleeve gastrectomy, and others less commonly performed. These are procedures which change the body's metabolism in a way that promotes weight loss and can cause remission or major improvement in diabetes control. So people may have surgery for a variety of health reasons in this respect. And so it's very potent surgery, and the effects on remission or reversal of diabetes, for example, are very striking and very potent. So I often recommend surgery to my patients with diabetes, after an extensive evaluation and careful thought. Unfortunately, some people do get a side effect of the surgery, and that's hypoglycemia, among other side effects. So we really want to understand this so we can not only develop better treatments for people who develop this condition, but also so we can predict who's going to be at risk, so we might be able to counsel them before they have surgery. And finally, the fact that just changing the stomach anatomy can change metabolism so much really tells us that there's a lot we don't know about how the intestine controls glucose metabolism. And that's important for understanding diabetes too. So that's why it's such an important focus of not only care that I give, but also research, because we really need to understand more about how the gut, the intestine, controls metabolism. So in people who have any of these surgical procedures, generally in the first year, their glucose metabolism improves, but they don't develop low blood sugars. But gradually over time, glucose levels can go down, especially after a meal. And so most of the time, the typical person that might have this condition might have had surgery a year ago, but even many years ago, 10 years ago, rarely. And they first notice that they're getting symptoms of hypoglycemia, maybe an hour and a half to 4 hours after eating. And it can progress over time and can be severe. So if glucose levels become low enough, they may develop all the symptoms of a low blood glucose, including severe low glucose, where they're maybe confused, they may pass out, may have seizures. Other people may have to help them to treat the low blood sugar by eating food or other treatments. So it is a range. Some people have it quite mild. Some people have it a more severe condition. So it is a range, but initially people thought that it wasn't happening very often, but more recent studies suggest that it may be as prevalent as 10 to 30% of individuals who've had these types of surgical procedures. Again, a range of severity. Some people not very severe, some people much more severe.
Dr. Patti, I've heard the expression of the dumping syndrome. Can you explain that?
So dumping syndrome is a term that's been around for decades. That I'm not fond of the term because people misinterpret it, but what it refers to are changes in your body's hormones that occur after eating in patients who've had some of these upper intestinal surgical procedures. So people after eating, let's say 30 minutes after eating, people may start to sweat, feel their heart pounding, feel lightheaded, feel like they just need to lay down. It's an overwhelming urge to lay down. And so that's what people have called early dumping. And that's due to the effects of hormones that are made by the intestine in response to eating, especially when the food comes out of the stomach too quickly. So when the food exits the stomach quickly, it hasn't had a chance to be digested. It hasn't been able to sit in the stomach for hours being churned around and digested. It just goes directly into the intestine. And that triggers these hormones, which produce all of those symptoms. Some of these same hormones ultimately cause the blood sugar to drop. And so that can occur an hour and a half or 2 hours or 3 hours after eating. So that those symptoms of dumping sometimes precede hypoglycemia. Some people with hypoglycemia, though, don't feel any of those symptoms and just develop hypoglycemia. So they're related, but not exactly the same thing.
The experience of not knowing what's going on. Now, typically with type 1 diabetics, for example, they're very concerned about unaware hypoglycemia. Is that also an issue with post bypass surgery patients?
Absolutely. So that's unawareness is when safety becomes a concern. So for someone who doesn't have hypoglycemia, if you acutely make them hypoglycemic, they will have all sorts of symptoms: sweating, shaky, heart racing, feeling hungry, and they'll know that it's time to eat or treat. But for individuals who've had recurrent hypoglycemia, the body responds by saying, I'm not going to make all these hormone changes, and the body doesn't respond as much. So people don't get the symptoms. And since they don't have any symptoms like the shaking, the sweating, etc., the first symptom that they have is confusion or some other cognitive problem. We call that neuroglycopenia. That just means that the brain doesn't have enough glucose to function. So if you don't get the warning symptoms, and the first thing is the brain symptoms, that's very dangerous, because all of a sudden you're not thinking well, your reaction time is slow, and you don't know it. And so those are the individuals where safety is really threatened because they're not aware until it's too late. And that can occur with type 1 diabetes or any condition with severe recurrent hypoglycemia. It's really just the body's response to turn off those warning signals because it happens so often.
Dr. Patti, if someone gets really severe symptoms that are very uncomfortable and tough to live with, from gastric bypass surgery, can they have it reversed? Has anybody said, I can't handle this, what else can I do?
Sure. That's usually reserved for people who have severe disease that's just not responsive to all sorts of other treatments that we use. So I wouldn't go there first. Many people respond to changes in their meal plan and other medications, which help to reduce the amount of insulin that their body is making and reduce the likelihood of a low blood sugar. It's really, why don't we just reverse everyone as the first approach? Well, when you reverse surgery, you don't really reverse everything. You can't reverse everything that's been cut. Even if you sew it back together, you're not, reversing everything. You can't connect all the blood vessels and the nerves and everything the way they were. So it's not truly a complete reversal. And understanding that, it's not surprising that you're not completely reversing the hypoglycemia in most cases either. Makes it better, but not completely normalizing it. So it's not a first choice.
Can you give us an idea the ages of the patients that are having this? Are they younger now? Are they more men than women? Are you doing teenagers now? I mean, can you give us an idea?
We see patients with hypoglycemia after upper gastrointestinal surgery of all ages. As I said, it takes at least typically a year or two after surgery, so that time delay, but it can occur in, you know, people in their 20s to people in their 70s, you know. Most of the people that we see this condition are women, but that's largely related to the fact that more women have surgery such as gastric bypass and sleeve gastrectomy than men do. There may also be an increased frequency of hypoglycemia in women as well, in some studies.
Okay. Are children having this? Are teenagers coming in for gastric bypass surgery?
Yes, but they're relatively small numbers of teenagers who have bariatric surgery. Usually that's done after very substantial evaluation by a team, because you want to really make sure that those individuals are prepared for lifelong nutritional and metabolic follow-up. But there's nothing, we don't think there's anything to suggest that younger individuals are more or less likely to have hypoglycemia as a complication.
Wow.
Dr. Patti,
Thank you so much.
Obviously, you know, no doctor wants to see a patient come in their door that has an advanced condition leading to type 2 diabetes or to gastric bypass surgery. These have become sort of solutions of our time as this pandemic of type 2 diabetes and obesity has, you know, swept the planet. On your website, it states type 2 diabetes is typically present for years before diagnosis, and individuals at risk for diabetes have insulin resistance and other metabolic abnormalities for years before that. The primary focus of the Patti laboratory is to identify the molecular and metabolic pathways which are disrupted in individuals at risk for diabetes. We are particularly interested in mechanisms by which environmental or nutritional factors can mediate risk. So just curious, you know, from your perspective, what are some of those leading factors? What are you looking at in your clinic? What's the, you know, the prevention story look like?
Well, there are no easy answers. I think we as a society have to examine our structure, our food sources, our built environment. There's so many factors that contribute to the unfortunate increases in obesity and diabetes, not only in the United States, but around the world. So no easy solutions. It's true that there are many patients who have diabetes that has been undiagnosed for many years, because again, diabetes is a silent disease and people don't feel poorly, so they may not see their physician, may not have testing needed to diagnose diabetes. And why is that of concern? Because if people have undiagnosed diabetes, that's associated with more cardiovascular disease, clogged arteries, increasing risk for heart attack and stroke. So we'd like to diagnose people with diabetes earlier so that we can avoid some of the complications. But even more importantly, we'd like to prevent progression to that stage. We know that maintaining weight and activity can prevent diabetes in people at risk. There have been very large studies over many years which have shown that. So what's challenging is to implement those preventive activities on a population level and even on a personal level. So there are challenges. So my research area of interest is, what are those things that might be preventable even earlier in life? So many people have probably heard that, for example, exposure during your development while you're inside your mother's uterus is a really important time when exposures to a mom who smokes, or a mom who has diabetes, or mom who has gestational diabetes, mom who may have alcohol exposure or drug exposure. All of these are exposures that the developing baby is feeling, is experiencing. And it turns out that many of these exposures can increase the risk of obesity in the developing baby. And so, you know, if we think globally about how we can best promote preventive strategies, maybe targeting even very early in life would be an attractive option. We're not there yet, but understanding why different environmental exposures during development can increase the risk of obesity, for example, is important if we're going to try to interrupt that process. So that's what we're investigating, is trying to understand those relationships.
We so much appreciate that focus that you have. We are seeing increasing numbers. You know, Roberta founded the Hypoglycemia Support Foundation over 40 years ago. And so she has an amazing long view on this from the consumer advocacy side. And she is seeing, and we are seeing, increasing numbers of parents coming to us with children who earlier and earlier in life are sick, have hypoglycemia, progression to type 2, and many other areas, you know, of concern. And so that, you know, I think you're looking back all the way to the womb is just it's wonderful to hear that you're looking at that. And we are seeing with the pandemic that there is certainly is a relevant area of concern. I mean, one article I saw reported a doubling of type 2 diabetes in children during the pandemic. I've also seen other studies now emerging that blood glucose dysregulation is linked to the entire life cycle of the virus and is emerging as a key factor in how people are able to survive and beat back the virus. Are you seeing, is this an area that you're looking at? And I think the other piece of this is we don't ever just see low blood sugar by itself. We often see high blood sugar, low blood sugar, in other words, this roller coaster effect. And I don't think a lot of people really understand that relationship, that dysregulation, that, you know, we call it the roller coaster. And I'm not sure that a lot of doctors understand that connection either. Just wondering if you could reflect on that.
Well, there were a lot of questions there.
Sorry.
In terms of the pandemic, I mean, it's really tragic that the pandemic has caused a change in many aspects of lifestyle that we aren't prepared for, right? And it's been a necessary public health effort, but it's unfortunately resulted in certainly more stress, changes in what people eat, less physical activity, and all of these things can certainly contribute, especially in people at risk, to weight gain. And, you know, I think that most of my patients, the majority of my patients have gained weight during the pandemic. And so it's not surprising that that's also occurred. I'm an adult endocrinologist, I should say, but it's not surprising that that's also translated to weight gain in children and more diabetes in children. You know, it's just one of those additional tragic consequences of the pandemic. The other thing that we've become acutely aware of in the pandemic is that people with obesity and diabetes are at higher risk of severe outcomes with COVID infection. And the data are very clear about this. Both with obesity and diabetes, there are changes in the immune system. And so if anything, the immune system is what we call pro-inflammatory. There's a lot of inflammation that occurs, and that can be protective in some cases, but in the case of COVID or severe illness, it can be counterproductive. So, you know, now is an important time to, you know, for patients with diabetes, for example, to talk with their doctors and make sure that their glucose control is as good as it can be. And for people without diabetes, improving your body's metabolism as much as you can on your own with becoming more active. You know, even walking is a great way to improve your body's metabolism. It's low cost, low side effects. You have to be careful where you walk and don't step into a hole, but you know, you can improve your metabolism even if you don't lose any weight. And so the message is that if you have diabetes and obesity and you have extra weight, you need to be extra careful in terms of both taking measures to protect yourself and your family, making sure that you're vaccinated, making sure that you're doing everything you can to optimize your glucose metabolism and your body weight and your physical fitness.
Dr. Patti, just before the COVID-19, we started an action alert, and we were very excited to post this up on our website. And this had to do with your petition concerning the continuous glucose monitor. It's still up there now, and we hope to revive it, because we were waiting thinking that, we'll restart it and reboot it. And, once COVID is under control, but it looks like it's going to be quite a while. So we still want to get back to it. So can you explain, why you're so passionate about sending, sharing this information, having the petition signed, what's exactly is the petition, and everything surrounding the continuous glucose monitor?
Sure.
The importance of it.
Sure. So as I said before, continuous glucose monitors are not for diagnosis, but they really help people maintain safety, particularly people who have unawareness, meaning that they can't sense when glucose levels are dropping to unsafe levels. So that's called hypoglycemia unawareness. And for those patients, whether they have type 1 diabetes or type 2 diabetes because they're on insulin and have recurrent hypoglycemia, or have hypoglycemia from an insulin-producing tumor, or hypoglycemia related to upper gastrointestinal surgery, or other forms of reactive hypoglycemia. If those individuals are unaware, that puts their safety can be threatened. So continuous glucose monitors can be very helpful in that setting, because the glucose monitors not only are monitoring the interstitial fluid glucose, again, not the same as the blood glucose, but can those monitors have alarms And the alarms can alert people to when when the interstitial glucose has fallen below whatever level is set by the user, or if the glucose is dropping quickly. And this can give them enough notice that they can treat it with food or glucagon or other forms of glucose, like glucose tablets, before the glucose becomes severe enough to cause their brain not to function. So it provides a layer of safety for people with severe hypoglycemia. I'm not suggesting that everybody with mild forms of hypoglycemia needs a continuous glucose monitor, but those with unawareness, it's really important. And the frustrating part is that glucose monitors are covered for people with type 1 diabetes, which they should be, no argument there, but they're not covered for someone with severe hypoglycemia, even though the insulin may be coming from inside their body, but they're not covered. So it's only covered if the insulin is being injected, whereas it's not covered if it's coming from inside the body. And that doesn't make any sense. Severe hypoglycemia is a threat, whether the insulin is from an injection or it's from your pancreas. And so the current Medicare laws, and that's what they are, really need to be changed in order to make any headway here. And so we really need some grassroots efforts to try to promote a change in that law, because it doesn't make any sense. It just doesn't make any sense all the way around. And we need to do our best to change that. So if there are any lawyers who are out there who are interested in helping this, I'd be more than happy to support that effort to a greater extent.
Right, Wolfram, can you do you know the link that our audience can go to?
The link is hypoglycemia.org/Medicare-petition, and we will put that link on the Facebook page and eventually on the hypoglycemia website where we host the blood sugar hotline videos. I just want to follow up on Dr. Patti's comments on the CGM, and also I wear a Fitbit as well. I'm diagnosed type 2. I'm one of those folks that, I wish I could have heard a lot of this information and had these tools available, 30 years ago when my pre-diabetes first emerged. I've found that the CGM has been really transformative if I actually pay attention to the data that I get. So in my case, I'm currently on assignment. I have a public health assignment here in southern Mexico, the sugary beverage consumption capital, possibly of the world. The population here in Chiapas, Mexico consumes over 2 liters of Coca-Cola per day. Obviously, way too much sugary beverages. And I've seen that my blood sugar has actually improved since I left the US, even though you might think that the Mexican diet is loaded with carbohydrates and, certainly a lot of delicious, what they call licuados and shakes and so on. But if I stay away from the tortillas and the rice and the potatoes and the fried bananas and all that stuff, and just stick to, for example, guacamole, which is a wonderful, healthy food that's high in healthy fat and very low in carbohydrate, stick to whole proteins and healthy fats, I've been able to get my blood sugar numbers down in the normal range, below the type 2 diabetes range. And I'm able to keep it there. And so if you do use the data, I think many people can actually see some reversal or very effective management of their type 2 diabetes symptoms. And then I match it with the activity. So I go out and walk every day, and I use my Fitbit. I try to hit 10,000 steps a day, but if I get 7,000 steps, I'm still happy with that. And so I find excuses to break up my day and go out and take a walk, as you said, and careful not to fall in a hole. You know, the sidewalks here are a little crazy in Mexico. But, you know, I'm really seeing a wonderful improvement. So I think the good news is that there really is hope. You know, there are tools available out there for people to use. And your focus on prevention going all the way back to the womb is really appreciated. But once people do reach that threshold and they are experiencing hypoglycemia on a regular basis or diagnosed type 2, what I'm seeing is that a lot of doctors, even in mental health, are starting to prescribe CGM monitors. We've interviewed another doctor, Dr. Ann Childers, who's a psychiatrist who built her practice around metabolic health. And she's been able to reverse many mental health, so-called mental health conditions in her patients because they realized that actually those symptoms, those mental health symptoms, are being driven by diet. So I think I think other fields of medicine are starting to see this the metabolic nature of the problem, relating that even dentistry, optometry, dermatology. I'm not sure if you've seen this, Dr. Patti. Are you seeing that other fields paying more attention to your work?
Yeah. So a couple of comments. So certainly there is an intimate connection between dietary factors, glucose control, and hormonal responses. And that's different from person to person. So even you mentioned some specific foods. Some people can eat food X and glucose levels stay fairly stable, but this other person would have a major change in their glucose, whereas another food may be a trigger for someone else. So there's a lot of variability, and there's some interesting large studies that have really shown that everyone's different. Some of that is related to differences in the bacteria in the gut that are present with us. And we're all different, not only ourselves, but also the gut that we host in the bacteria that we host in our gut. And these can all influence our body's metabolism in response to food. So I think that for a motivated person who's interested in making changes in their lifestyle, both activity and food, a continuous glucose monitor can be a tool that helps them. Oh, I eat 5 pieces of bread and clearly my glucose spikes up to 500. Whereas if I eat half a slice of whole wheat bread, nothing happens. I mean, I'm exaggerating an example, but so I think that there is the opportunity to use data like that in combination with step counts and other trackers to help people make individualized choices that will improve their health, no doubt. The other thing was, hormones affect every organ in the body, right? There's nothing that escapes the influence of your body's metabolism. I always got a kick out of the comment that the heart exists just to pump the hormones around. I mean, so it's all organs of the body, all tissues in the body are affected by glucose, amino acids, fats, hormones. So the idea that your metabolism can affect all of these organs is absolutely the case. Most of the time it's happening in the background and you're not aware of these relationships. I do think you mentioned specifically psychiatry. I think there's an interesting emerging science about the relationship between the gut and the brain and the connections that between the gut and the brain that can influence health. I think we don't know enough. We don't have all the answers, but clearly there's a lot of interesting work that's going on, and I think more information will be very important.
Well, thank you. We've covered a lot of ground, and I feel like we really would love to have you come back for another show at some point. We've got a few more programs lined up in the next few months with some exciting speakers, but I know your work is ongoing, and I imagine you have a number of subjects you'd like to make people aware of and help. And we really appreciate your deep dive on the issue of hypoglycemia and post-bariatric surgery patients. Because clearly they're not getting enough attention. We need more resources. We just want to say how grateful we are for your time and your expertise today. There's been a lot of folks watching on Facebook. We will post the video so people can watch in their own time if they couldn't join us at the moment. And we'll also have the video available on our website. But we're deeply appreciative of having you as an advisor and learning of your work and just learning from all the research you do, and glad that you're also in practice and helping patients too. So you have that real world connection. So thank you.
Oh, my pleasure. Thank you for the invitation.
Thank you so much, Dr. Patti. It was such an honor and a privilege.
Nice
Take
to see
care.
you both.
Bye-bye now.
Bye.
Thank you.